Welcome, everyone, to this year's annual Midwestern Vascular Surgical Society meeting. I'm Bernadette Aulivola, and I have the honor of serving as the president of this organization this year. So it's an honor to serve in that role. I'm excited to see you all here. This is our 48th annual meeting, and I'd like to thank Dr. Milner for his skills as our program chair. We had a whopping 136 abstracts submitted to the meeting, of which you will hear 29 plenary talks. We are giving out 4 presentation awards this year for clinical, venous, basic science, and disparities-focused research, so we're excited about that. You'll also hear 11 case reports throughout the course of the meeting, 13 rapid-fire presentations, and we have a poster competition tomorrow evening, which I hope you can join us for, that we will award the best poster award to for an individual who will get to present their poster at the podium on Saturday morning. So lots of exciting stuff happening. I hope most of you were here for our industry-supported lunch symposium, Discover the Latest in Peripheral Intravascular Lithotripsy, and I want to thank Shockwave Medical for their continued support of the Midwest Vascular Surgical Society. I would like to thank all of our industry supporters in making this meeting possible, and I hope that you'll take some time to visit them in the lobby out front and also in the exhibit hall around the corner during our breaks. A few reminders to those of you presenting. Please disclose any relationship with industry prior to the start of your presentation. For those with plenary papers, you are required to submit your manuscript to the JVS within 90 days of today. Case report and rapid-fire presentations, while you are not required to submit, we highly encourage it. We love to see our work out there in print. I mentioned the poster presentation tomorrow evening. But in addition to that, if you walk through the lobby, you'll see some monitors up where we have a number of e-posters that will be cycling through, and those won't get verbally presented, but those will be there for your viewing throughout the course of the meeting. So we hope that you'll take the opportunity to visit those. For our associate members and allied health professionals, we are continuing with our annual Advanced Practice Provider program that'll be held tomorrow morning, starting with a breakfast at 8 in the Grant Lincoln Room up, I think that's up one floor. So again, thank you for your attention. We're excited to get started. I'd like to introduce my co-moderators here. We're continuing the tradition of having a candidate member as part of the panel for each of our sessions. So we have Dr. Megan Parrott, who is a second-year fellow at University of Iowa. And also with me this morning or this afternoon is Dr. Simon Fraser from Ohio Health. I'd like to welcome the first presenter up to the podium. The first abstract is entitled, A 30-Day Smoke-Free Window Prior to Carotid Endarterectomy in Asymptomatic Patients Reduces Stroke Risk to Never Smoker Levels. And this is presented on behalf of the group at Henry Ford Hospital and Michigan Health. Thank you.
Good afternoon. My name is Hassan Shamsuddin. Thank you for the opportunity to present this work. We have no disclosures. The Society for Vascular Surgery currently recommends carotid endarterectomy over best medical therapy for patients with asymptomatic carotid stenosis greater than 70%, with evidence of benefit coming primarily from the landmark ACAS and ACST1 trials. More recent trials, however, including the SPACE 2 trial, have shown no difference in stroke prevention between endarterectomy and best medical therapy for asymptomatic patients. In light of the uncertainty of the benefit for this operation in asymptomatic disease, it remains essential to optimize the outcomes of endarterectomy when performed for asymptomatic carotid stenosis. Various approaches have been proposed as having the potential to improve the outcomes of this operation. Of those approaches, smoking cessation has been posited with the potential to mitigate the stroke risk in this patient population. Accordingly, the aims of the study was to evaluate whether smoking status influences the short and long-term outcomes of carotid endarterectomy in asymptomatic carotid stenosis. All patients receiving a carotid endarterectomy in the Vascular Quality Initiative between 2013 and 2023 were reviewed. Of those, patients receiving an operation for asymptomatic carotid stenosis in an elective setting were included. Patients with an ipsilateral stenosis less than 70% and those who underwent a concomitant CABG were excluded. Patients were split and compared according to their smoking status into never smokers, former smokers defined as those who quit smoking at least 30 days prior to their operation, and current smokers. A total of 77,000 patients with a mean age of 71 years were included, of which 41% were females. Half the population were former smokers, whereas a quarter were current smokers and a quarter were never smokers. Baseline demographics and characteristics varied between the three groups. Notably, current smokers were younger and less likely to have hypertension, diabetes, heart failure, and a prior CABG or PCI. On the other hand, never smokers were less likely to be male and to have COPD and coronary artery disease. Procedural details including anatomic high risk, ipsilateral stenosis and contralateral stenosis, type of endarterectomy performed, the need for patch, shunt, and cerebral monitoring also varied between the three groups. When looking at perioperative outcomes, outcomes including hospital stay, stroke, myocardial infarction, death, and cranial nerve injuries did not differ between the three patient groups. Nonetheless, when looking at the long-term outcomes, never smokers and former smokers, represented by the blue and red lines respectively, had a similar stroke rate over the 18-month follow-up. This was significantly less than that of current smokers, represented by the black line. At 18-month follow-up, never smokers and former smokers had the same stroke level of 0.8% and 0.85% respectively. And this was significantly lower than that of current smokers at 1.5%. Those findings persist on multivariate analysis, showing no difference in outcomes in stroke outcomes between former and never smokers. Nonetheless, former smokers had a 32% reduction in stroke compared to current smokers. When looking at major adverse cardiac events at 18 months, former smokers had a significantly reduced MACE outcome of 12% compared to current smokers at 13%, but that was significantly higher than that of never smokers at 9%. Those findings also persisted on multivariate analysis. A similar trend was observed for mortality. Quitting smoking reduced the outcome of mortality for former smokers, but that was still significantly higher than never smokers. So in summary, smoking status has no effect on the perioperative outcomes of carotid endarterectomy in asymptomatic disease. Patients who quit smoking at least 30 days prior to their operation have a similar 18-month stroke risk compared to never smokers at 0.85%. However, current smokers have a significantly higher 18-month stroke rate at 1.5%. So in summary, quitting smoking reduced stroke risk by 30% at 18 months follow-up, MACE by 25% at 18 months follow-up, and long-term mortality by 20%. This study had a few inherent limitations. First, we were limited by an 18-month follow-up period due to the nature of the VQI. Second, some patients who were grouped as former smokers in this study may have resumed smoking after their operation. However, this only means that the benefit of smoking cessation may have been underestimated in this study. So in conclusion, postponing carotid endarterectomy for smokers with asymptomatic carotid stenosis until they have refrained from smoking for at least 30 days may improve long-term stroke, MACE, and mortality outcomes. Thank you.
Dr. Rossi.
Thanks. That was a really nice paper and very well presented. So let me ask you this. Given the very low event rate for asymptomatic carotids, should we start treating asymptomatic carotids like brain claudication and just tell people that we are not going to intervene if they're smoking? But or how should we be that aggressive? What's your thought based on your manuscript? Thanks.
So we do agree that there is some form of uncertainty over the benefit of intervention for asymptomatic patients, and this is why we are all waiting for the CREST-through trial outcomes. I think the results from CREST-through will be what's practice changing for asymptomatic carotid disease. But as of now, if we do want to follow SVS guidelines and do intervene for asymptomatic disease, we have to make sure to maximize the benefit of this operation by doing some strategies, including having patients stop smoking ahead of time.
Next question.
Hi. One of the things that I would like to just say that we should be very careful about is that WQI doesn't distinguish between a smoker who quit five years ago versus 5 weeks ago. So what you're just trying to say is that patients who make healthy choices do better from a stroke standpoint, etc. And if you have a patient in your clinic who has severe stenosis who you think meets your criteria for a surgical repair, I'm not sure that stopping smoking for 30 days would like really change much for that particular patient. Just like to caution that.
Thank you for your question. So we do agree that this is one of the limitations of the study as to we don't have the exact duration for each patient, when did they stop smoking or not. Our former smokers group was composed of a heterogeneous mixture of patients who stopped years ago, patients who stopped at least 1 month ago. But I believe that the message behind this is if we do want to intervene for asymptomatic disease, let's try to put in some effort to improve the outcomes as much as possible. 30 days may not be enough, but it may be a good start too.
Mark Manos from Michigan Vascular Center. Isn't the real question, though, is not the preoperative stopping of smoking, but the actual, did they continue to stop smoking in the postoperative 18-month period? Because that's really, it's going to be what triggers their MACE, not other than the initial 30-day perioperative results, right? So do you have any data on whether or not they continued to stop smoking in the 18-month follow-up? Because that would make the paper better and would give us more of a tangible evidence about how we want to address these patients.
Thank you for your question. So we do not know if each patient continued smoking after their operation or not. We address this as one of the limitations. However, we do believe that given that we treated those patient population as former smokers and we did show some benefit, it means that in case a subgroup of those patients continued smoking after their operation, then this study only underestimates the benefit that we show. So the benefit does exist. It may be underestimated because some former smokers may have resumed smoking after their operation, but the benefit is there.
All right, we'll have to move on. Thank you so much for your
Thank
talk.
you.
Our next presenter will be discussing differences in growth and shape between symptomatic and asymptomatic abdominal aortic aneurysms from the University of Michigan in Ann Arbor.
Thank you for the opportunity to present our work. We have no disclosures. So we all know that AAA rupture has a high risk of mortality, and we all know that the increased risk of rupture can be partially attributed to increasing maximum aortic diameter. But maximum aortic diameter does not account for all the complexities of AAA morphology, and it may actually be an inadequate marker for rupture risk when used alone. So if you think back to your high school physics class, you may recall the law of Laplace. This states that for a simple sphere or cylinder, the wall tension is directly proportional to the radius. And as this audience knows, a standard AAA is definitely not a standard or typical sphere or cylinder. There's a lot of different complex features and morphologic components that go into the AAA, thus making these two not directly equivalent. So how about volume measurements? They've been proposed as a promising adjunct to diameter measurements. But volumetric measurements don't provide any information as to the location of growth, and data regarding volumetric changes over time and how they relate to growth and rupture are actually really lacking. So our group has previously worked on a technique called vascular deformation mapping. Essentially, this technique works as such. If you have two different CT scans across different time points, then you can get a 3D rendering or a segmentation of the anatomy of interest, in this case, the aorta. And we use something called deformable image registration to essentially compare how that aneurysm grew in 3 dimensions. And that map, it's a little small on the bottom right, is how that aneurysm grew from its baseline anatomy. In this prior work, we've demonstrated that there's significant discrepancies in growth assessment between maximum diameter and VDM-derived 3D growth maps. So the aims of this study were to quantify differences in shape and volumetric growth patterns between symptomatic and asymptomatic AAAs. We retrospectively identified patients over about a 13-year period using ICD codes and included patients who had 2 or more high-quality CT scans that were completed prior to having surgical repair. We reviewed their chart to determine the symptomatic status of each patient, and then we used an automated segmentation software called Prave Aorta that we then manually confirmed and edited when necessary using 3D Slicer. This is a screenshot of some of the information that Prave Aorta gives you. You can see it just gives you a lot of detailed information about the infrarenal aorta itself and then also the neck. So we collected patient variables, maximum diameter, AAA volume, the intraluminal thrombus volume, and the aortic flow lumen volume, as well as neck measurements, and we obtained each of these at each CT scan. And then we can calculate the changes in diameter and how those changed over time. We also did a shape analysis, and for that we matched a cohort of 12 symptomatic AAAs and asymptomatic AAAs on sex and maximum diameter. And this was done using a software called the Vascular Modeling Toolkit. And our metric of shape is distance to center line. So you can imagine if you have a CT scan, you could obtain the center line of that. Then you can point how each point of that surface, how far away it is from that center line, and that gives you a 3-dimensional rendering of the shape as a distance to center line. Likewise, if we have a scan at another point in time, we can do the same thing. Presumably this one grew in this example, and then we can compare the two to get a marker or a metric of 3-dimensional growth. So aortic segmentations were then split into 8 anatomically and clinically relevant zones, and we did this to allow for reproducible quantification because not every aneurysm has the same neck length or aneurysm length, and that way we can really quantify differences in shape and growth. So this is just a depiction of the different segments we have. Essentially, it's the neck itself, the aneurysm itself, anterior, posterior, right lateral, left lateral. And then lastly, we did something called statistical shape modeling, and this was used to compute mean shapes of the symptomatic and asymptomatic AAAs. I assume most of the people in this audience probably aren't familiar with SSM, but in general, if you have an anatomy of interest, in this case the aorta, and you segment that so you get a 3D rendering of it, you use common coordinates to find likewise or similar features to the renals and the iliac, and then you can basically find corresponding points for each aorta of interest and compute a mean shape of each aorta in the group. So we had 55 patients, 12 of whom became symptomatic, 43 stayed asymptomatic at follow-up. You can see that for the symptomatic patients, they were on average younger, less likely to be Caucasian, and interestingly enough, actually less likely to have hypertension. When we look at the diameter and volume measurements, there was no difference in the maximum diameter, the AAA volume, the ILT volume, or the aortic flow lumen volume between symptomatic and asymptomatic AAAs. And when we look at how those measurements changed over time, although there was no difference in the change in maximum diameter, there was a higher increase in the aortic volume for symptomatic patients and a larger increase in the aortic flow lumen volume for the symptomatic patients when compared to the asymptomatic. This is our statistical shape models. So you'll see that we have the asymptomatic patients and the symptomatic. This is the average of each aorta. And you can see that on the symptomatic patients, it appears to be a more focal shape or a focal dilation of shape. And the asymptomatic definitely appears more diffuse. There's more red diffusely and on the posterior aspect as well. And then this is just a violin plot showing each of those corresponding points. And then interestingly enough, when we look at the differences in shape across our 8 defined segments, there's actually no difference between symptomatic and asymptomatic aneurysms when we're quantifying them across those segments. But when we look at growth, we do see that the symptomatic patients have a much higher growth in the left lateral neck than the asymptomatic patients, although there was no difference in the amount of growth in the other aortic segments. So symptomatic AAAs had larger increase in AAA volume and aortic flow lumen volume over time when compared to asymptomatic AAAs. And this was despite no difference in diameter, volume, or change in diameter. We did not find quantifiable differences in shape, but we are potentially seeing some qualitative shape differences. Right now, we're playing around with using a different kind of zoning strategy. We wanted to make it clinically relevant, but it's possible that we're just averaging out those differences over large segments. Symptomatic AAAs have larger three-dimensional growth in the left lateral aneurysm neck. And this shows that volumetric changes in growth can be maybe better predictors of AAA rupture risk, but we definitely need larger scale and prospective studies before we're really confident in those findings. So I'd love to thank the selection committee for the honor of the podium. Thank you to my mentors in the lab, and thanks to our funding, and happy to take any questions.
Drew, fascinating presentation. Now, are you able to tell us a little bit more about the volume changes and how, over what period of time? Because currently we are no smarter than where we are at this stage. I think if you can tell us that what was the volume growth that you noticed and how it's going to impact the decision here.
Yeah, let me see if I can go back. That's a great change. I know I had a lot of data that I might have briefed over. It looks like I'm not able to go back. Well, so the nice thing about the data, or what we tried to do to make this comparing apples to apples, is we did not match on CT intervals. So in theory, one patient might have had a CT interval of 5 years, where one patient might have had a CT interval of 6 months. And obviously those two aren't direct. So when we show those volumetric growth rates, it is in centimeters over month. So they, in theory, should have, the interval of CT shouldn't necessarily matter. And to answer more specifically on your question, I'd go back to the slide. I think it's in the booklet, some of the numbers there. But we are seeing that in the total AAA volume grew over time, and then specifically the aortic flow lumen volume grew higher over time. And we didn't see a difference in the intraluminal thrombus, which I think that was probably just because there's a lot of variability in that between each. But it certainly goes to show that maybe we should be using adjunctive measures when we're looking and counseling these patients.
Iraklis Pepinos from Nebraska. A very nice presentation. I am a little confused about the thrombus component. So the volume increases and the flow lumen volume increases. The interpretation would be that the thrombus decreases, but there was no, was it also increased in the symptomatic patients? Maybe you can help us understand, because this is very beautiful work, and thank you for doing it, but maybe you can explain what do you think is happening, and is resorption of thrombus potentially having something to do here?
Yeah,
thank you.
Thank you for the question. I think that's a really important one. So to clarify first, and I'll go towards the last part of your question, the thrombus did increase over time in both cohorts. And we saw a signal for an increase in thrombus, or a larger increase in thrombus, rather, for the symptomatic patients. It just didn't reach statistical significance, which is probably just because I only have 12 asymptomatic AAAs. So I'm not really sure. When I first thought about this work, I thought that the thrombus might be the most interesting component of this, because there's definitely some controversy in the literature about its role. I just don't think we have the numbers really to definitely say that. So if anybody out there has a bunch of symptomatic AAAs that they want to let me segment and work on, please reach out. I'd love to have some more patients.
One last question, Dr. Kabani.
Yeah, really nice work. I'm just looking at the numbers. For symptomatic AAAs, the average size was 5. And I guess my question is you probably, like you said, you probably need more numbers and bigger aneurysms. But was that correct? 5 was the average? Yeah.
And I'll look back. I think that might be the median, so it might not be the average. But I think in the abstract it might be average, and then in the presentation I had median and interquartile range. But yeah, they were surprisingly small, whether it was average or median.
And this may be something that the society may want to join as a group and give you data. That's something that we could think about.
I would love that.
Thank you.
Thank you.
Thank you very much.
All right, our next presentation will be Enhanced Recovery Pathway for All-Comer Infrainguinal Bypass Decreased Length of Stay, presented from Northwestern University.
Good afternoon. Thank you for the opportunity to present our work. We have no relevant disclosures. First termed fast-track surgery in the early 1990s, enhanced recovery protocols have gained traction within multiple surgical specialties. These include cardiac surgery, colorectal surgery, orthopedic surgery, and most have demonstrated significant benefits to patient mortality, complication rates, as well as length of stay and cost overall. And generally, most of these broadly incorporate multiple stakeholders involved in the perioperative care of surgical patients. These include surgery, anesthesia, nursing, and also encompass all phases of care, including preoperative outpatient workup, preoperative within the hospital, intraoperative, and postoperative phases of care. However, the evidence and the implementation of ERAS protocols or enhanced recovery protocols within the vascular surgery patient population specifically is somewhat scarce. The Society of Vascular Surgery has recently joined with the Enhanced Recovery After Surgery Society and the ERAS Society in developing a framework for perioperative care after lower extremity arterial bypass. This was published in 2023 and sort of our society's first foray into enhanced recovery. Of the 36 key recommendations, only 11 were rooted in high-quality evidence, with the remainder rooted in moderate or low-quality evidence. And so we aim to develop an enhanced recovery protocol for all-comer lower extremity arterial bypass across an entire healthcare system. And we hypothesized that enrollment in the ERP would improve patient postoperative outcomes after lower extremity arterial surgery, arterial bypass surgery. To initiate this, we developed an ERP QI committee. This involved multiple stakeholders from the surgical team, including faculty, trainees, APPs, members of the anesthesia team, members of the pharmacy team, as well as critical service such as dietary, physical therapy, and occupational therapy. We use the Quality Enhancement Research Initiative model to develop and guide our implementation of the ERP across the 3 major hospitals within the central region of our healthcare system. Shown here is a checklist that encompasses most of the elements, not all, of preoperative, both inpatient and outpatient preoperative ERP elements. Checklists were made to help guide the surgical team for all phases of care. Notably, all ERP elements, when able, were accompanied by changes to the electronic medical record, including changes to the case request instrument, changes to smart phrases, as well as order sets for both preoperative and postoperative phases of care. Highlights in the preoperative elements include early cessation, shortened duration of NPO status, allowing for clear liquids up to 2 hours preoperatively, the initiation of a pre-surgery carbohydrate loading drink, as well as chlorhexidine washes. Intraoperative components involved phases of standardization of surgical, nursing, as well as anesthesia workflows. These were all, many of these are part of existing workflows, but sort of formalized as part of the enhanced recovery protocol. There's a particular emphasis on opioid-sparing analgesia, in which we were loading patients preoperatively with acetaminophen, using ketamine routinely, and in discussion with our anesthesia colleagues, routine use of Zofran and Decadron to mitigate postoperative nausea and vomiting. Postoperatively, these elements are particularly aided by the use of order sets that were enabled within the electronic medical record. Other focuses include early ambulation, early consultation to physical therapy, occupational therapy, early advancement of diet, and early cessation of intravenous fluid. The enhanced recovery protocol was sort of launched or went go live in February of 2022 across the entire central region of our healthcare system, and patients were enrolled at the discretion of each individual vascular surgeon. At 20 months, data was abstracted from a single site for univariate analysis, and then ultimately from a single site. Shown here are patient demographics. Notably, there were some significant differences. 112 patients underwent lower extremity arterial bypass during this time period, 60 in the enhanced recovery pathway and 52 in the traditional pathway. You can see there are major differences in smoking status, bypass indication, as well as case urgency. For instance, we can see there are more emergent cases in the traditional pathway, as well as more cases for acute limb ischemia in the traditional pathway. However, there were no differences in sex, BMI, race, or hemoglobin A1C between the 2 cohorts. Regarding day of surgery data, we found that there were no significant differences in infragenicular target as acting as a proxy for potential surgical case complexity. We did find that there was no difference in operative duration. However, there was a significant difference in estimated blood loss with a reduction in an ERP cohort. There were also significant differences in the amount of ketamine and dexamethasone administered to patients, though this was likely expected given the focus on them in the enhanced recovery protocol. Postoperatively, we found that ERP patients had reduced total length of stay as well as postoperative length of stay, with an average of about 6 days after a lower extremity bypass in an ERP cohort. We also found that there was a reduction in unplanned return to the OR. We did not include planned procedures such as fasciotomy closure in this analysis. There were no differences or significant differences in 30-day unplanned readmission or 30-day mortality. Given the introduction of a preoperative carbohydrate loading drink, especially in a patient population rife with diabetes, we also evaluated perioperative glucose. We found that there's no significant change in postoperative or perioperative glucose between the ERP cohort as well as the traditional pathway cohort. Given that not all patients received a carbohydrate drink, as you know, compliance is not 100%, we also evaluated whether perioperative glucose would change with administration of these drinks, and there was no significant difference. What is interesting is that the development of ERP also improves both existing and novel process measures. Successes include early ambulation, early cessation of intravenous fluids, early advancement of diet. Challenges remained preoperative acetaminophen loading, protein supplementation as well. So in conclusion, we found that enhanced recovery pathway for lower extremity arterial bypass is feasible in both elective and non-elective settings, and that the ERP was associated with a reduced length of stay as well as unplanned reoperation. And notably, ERP was associated with both increased compliance with novel and existing process measures. There are certainly limitations to our study, including its single-center design, as well as enrollment via surgeon discretion, as well as a limitation of no evaluation of cost as a quality metric. Our ongoing future directions include a 100% enrollment in the ERP at our institution, evaluation of our performance in national databases such as Vizient or VQI, and then expansion of these protocols to other vascular surgery procedures such as open aortic surgery. Thank you again to the Society for the opportunity to share our work, and to my PI, Dr. Vavra, for her mentorship, as well as the entire division at our institution, as this is really a team effort. I'd be happy to take any questions. Thank you.
Two questions. First is, do you have the two groups that you compared, do you have their frailty scores? Were they pretty similar? That's question number one. Question number two is that how did you account for unplanned takebacks for secondary surgeries when commenting that one group had a shorter length of stay compared to the other?
Sure. So we did evaluate, I guess as a compliance measure, a modified manuscript frailty index. I did not include that in analysis, but that's something we can certainly include in the final manuscript. And then we looked at unplanned reoperation within 30 days, so certainly baking some of that into the readmission as well. So we did find that there was a difference in unplanned reoperation, using that as our metric.
Thank you. Thanks for your presentation. I wonder if you can expand a little bit on surgeon discretion, because the surgeon decided whether the patient should participate, and then the patients were randomized to a new protocol versus standard, or were they certain patients were selected to participate and the rest were the comparison group? That was not clear.
Sure. Thank you for your question. So that is certainly a limitation, and you highlight that nicely, in that ultimately surgeons made the ultimate decision whether to initiate the protocol. And again, even if they were initiating the protocol, there was not necessarily 100 compliance with the aggregate interventions in terms of all the ERP elements. So it was ultimately up to each surgeon for each individual patient whether to initiate the protocol for them.
Thank you very much for that. I want to congratulate you. That's a monumental effort. It's really hard to change people's practices and bring all those people together. And just to be able to do that's a feat. So thank you for bringing that to the forum. The question just sort of piggybacks on that one is, do you have a sense for who put people into the pathway? and who didn't put people into the pathway, or why were they not put into the pathway? Just to sort of put the results in context, is it certain providers who maybe were less inclined to go into the pathway, or was it patient groups who were less inclined to be selected to go into the pathway? Thank you.
Sure. Thank you for your question. We did not stratify by individual attending surgeon, but that's something we could evaluate, whether it's down to the individual. Based purely just looking at the data set, I didn't notice any obvious trends, and that was all one surgeon in the protocol versus no patients in the protocol by another surgeon. I think one of the major barriers is, I think, overnight when emergent cases come in, which is evidenced by our differences in case urgency and emergency, or our indication was at night it's very difficult to initiate all these things when there's a limited coverage. A lot of this is rooted in education, and it's certainly the main vascular team that is most facile with gathering all the elements. And this is where order sets and changes to electronic medical record really sort of emphasize or make this easier to implement.
Hi, this is Michaela Thomas. I'm a Chief General Surgery resident at Wright State. Thank you for your talk. I have a question, a comment. The question is what was the biggest thing as far as, because especially in general surgery, ERAS is so huge for us. What was the biggest thing that makes up your ERAS, especially for vascular patients? Is it getting them up out of bed right away? Like you talked about the carbohydrate drink and controlling their glucose after surgery. So that's my question. And then I definitely think this would be a great study for, like we do it for all our open aortas and aorta bifems at Kettering Hospital in Dayton. We don't leave an NG tube after surgery. We put them on clear liquids right away, and then they're advanced to regular diet. We get them up out of bed right away. So I think it's definitely that population would definitely be good to look at. So thank you.
Thank you. You're absolutely right. It's very difficult to ascertain which specific element when it's such an aggregate of interventions. But I think that certainly a lot of the emphasis on early physical therapy and normalization of patients in the postoperative period, I think, is one of the larger contributors to this. And I think that one of the challenges within our patient population is they're much frailer, much sicker than the colorectal orthopedic patient population. And so we also don't have easy surrogates such as return of bowel function for colorectal surgery, ability to tolerate weight-bearing status for the orthopedic surgery. So we don't have as great of a surrogate as in terms of a clinical outcome versus other specialties. But I think there's a lot of work to be done.
Thank you. I think we're out of time for questions, so apologize about that. There's obviously a lot of discussion generated here, so that's always a good thing. So thank you for your presentation.
Thank you.
All right, we're moving on to the next presentation. It's entitled Improvement in Optimal Discharge Medications Within the Vascular Quality Initiative is Associated with Improved Long-Term Survival, presented by Venkata Vadavali and representing the Mayo Clinic in Rochester and Scottsdale.
Good afternoon, everyone. Thank you for the opportunity to present. We have no relevant disclosures pertinent to this study. More than 50% of the patients undergoing vascular surgical procedures have concomitant coronary artery disease, leading to higher rates of cardiovascular morbidity and mortality in these patient populations. Treating them with both antiplatelets and statins have shown to reduce 30-day mortality and improve long-term survival. Multiple societal guidelines recommend optimal medical management with both antiplatelets and statins in these patients. Even then, optimal medical management is underutilized in patients with vascular disease. The recently published American Heart Association guidelines recommend optimal medical management with both antiplatelets and statins in patients with peripheral arterial disease. In our previously published study in 2014, we found that patients discharged on both antiplatelets and statins had 26% absolute improvement in survival, which was 81% in patients treated with optimal medical management and 55% at 5 years in patients on neither of them. We also found that as the number of years of participating in VQI increases, utilization of optimal medical management increases from 58% at 1 year to 69% after 10 years of participation in the VQI. The purpose of the current study was to evaluate the effect of this landmark publication on uptake of optimal medical management in the Vascular Quality Initiative and its association with long-term and short-term outcomes before and after this work. we analyzed all the patients undergoing vascular procedures from 2005 to 2022 in the VQI and limited our analysis to only first-time procedures and elective cases. The patients were divided into two groups based on the year of surgery. Patients who underwent procedure between 2005 to 2013 were included in Group 1, and those who underwent procedure between 2014 to 2022 were included in Group 2. The year of cutoff was decided based on the publication of our previous study. Outcome was to study the trend in the utilization of optimal medical management at discharge during the study period and its association with long-term survival. We utilized interrupted time series analysis to assess temporal trend in the utilization of optimal medical management, and Kaplan, Mayer, and Cox proportional hazards was utilized to analyze time to event data. During the study period, we had a total of 835,000 patients, and after excluding emergency cases, those who had missing medication data, and those who died in the hospital, we had a total of 522,000 patients, with 69,000 patients who were operated before 2013 and 450,000 patients in Group 2. When Group 1 and Group 2 were compared, there was increase in the peripheral endovascular interventions, carotid artery stenting, and decrease in infrainguinal bypass, open aneurysm repairs, and carotid endarterectomies in patients operated after 2014. We studied the trend in the utilization of optimal medical management over the years and found that there was significant increase in the rate of utilization of optimal medical management from 2005 to 2022, with 80% of the patients being treated with optimal medical management in Group 2 compared to 71.7% in Group 1. When the rate of utilization between Group 1 was compared to Group 2, there was no significant difference. This can be due to more centers participating in the VQI around 2011, which might have led to bias. To eliminate this bias, we did a sensitivity analysis by limiting our analysis to the centers which started participating in 2005. We found that the rate of utilization of optimal medical management has significantly increased from 2005 to 2013 and stabilized after that. Survival analysis was done based on the patient's discharge on optimal medical management. We found that patients treated with both antiplatelets and statins had significantly increased long-term survival at 10 years, which was 77.7% compared to 73.8% in patients treated with neither of them. When the survival analysis was done based on the year of procedures, we found that patients operated after 2014 had significant improvement in survival, which was 79.4% at 10 years compared to 73.7 years in patients operated before 2013. On multivariate analysis, after adjusting for demographics, comorbidities, and prior vascular interventions, patients who were treated after 2014, that is in Group 2, had lower risk of mortality, and patients who were neither treated with antiplatelets or statins had increased risk of mortality in the long term. In conclusion, improvement in optimal medical management in the VQIs has been studied since 2005, approaching 80% in the current practice. Optimal medical management continued to be significantly associated with improved long-term survival. Therefore, managing patients with both antiplatelets and statins is vital for improved outcomes after vascular procedures. And lastly, participation in vascular quality initiative can lead to improvement in quality measures and outcomes. Thank you, and I'm happy to take any questions.
Thank you. So were there any subsets of the patients that you looked at that benefited more significantly from optimal medical management?
We did stratify the patients based on the procedures, but we did in every procedure there was a significant increase in the survival. But for this study, we combined all of them based on the time periods to look at the effect of that publication in improving the quality measures over the country.
Okay. Thank you. Dr. Pepinos.
I was impressed by the 2009 uptick and then the disappearance. Maybe you can discuss that a little bit. And then you showed some data about patients who were on optimal medical management both pre and at discharge, before operation at discharge. Did that increase, meaning did you see also an increase in the number of patients who were not at optimal medical management pre-op, but then at discharge, OMM was instituted? Thanks.
Okay. Initially, the number of, for the first question, the number of participating centers in the VQI in 2005 were very low. And as we see the number of years of participating in the VQI increase, patients being managed with optimal medical management also increased. But then in around 2009, 2010, and 2011, a lot of centers started participating in the VQI. That led to a dip in the utilization of optimal medical management, because those centers might have not put the patients on both antiplatelets and statins at discharge, but eventually it started increasing again because of the quality measures being taken by the VQI. So that might have led to the peakness at 2009, followed by a dip and then increase again. And to answer your second question, we have the data on pre-op medications and post-op discharge medications. We found that both, when we analyzed data based on preoperative medication, we found the increase in long-term survival as well as in discharge medication. But I don't exactly remember how many patients were treated with optimal medical management in the pre-op and how many of them are treated in the post-op. I have the numbers, but I can definitely put it in the manuscript.
Thank you.
Thank you.
Our next talk is personalizing decision-making for asymptomatic carotid stenosis using artificial intelligence from Indiana University and Oklahoma State.
All right. Thank you. Let me adjust these a little. All right, thank you for having me. We've no relevant disclosures. Deciding when to intervene on asymptomatic carotid stenosis continues to be a controversial topic. Landmark studies such as ACAS and ACST attempted to delineate stenosis criteria to determine mortality benefit and stroke risk. However, medical therapy and smoking cessation approaches are much improved since these study periods, as has intraoperative stroke risk. These advancements beg the question whether the recommendation should change. In light of more modern approaches to answer this question, promising work investigating plaque characteristics in asymptomatic patients has been performed. However, more data is needed prior to plaque rupture to draw stronger conclusions about at-risk pre-rupture plaque morphology. With an abundance of emerging technology to help physicians and scientists answer challenging questions, we sought to use a different approach to this dilemma. Subsequently, the goal of this work was to determine if a machine learning review of electronic medical records can distinguish asymptomatic patients who are at greater risk for stroke than others. We had 872 patients who underwent carotid intervention at Indiana University affiliate hospitals between 2009 and 2022. 408 patients underwent a carotid intervention for stroke, TIA, or amaurosis. 464 patients underwent carotid intervention for asymptomatic carotid stenosis, greater than 70%. And these were all verified by a vascular surgeon chart review. Available diagnoses, laboratory tests, medications, demographics, and other available information was analyzed from the EMR. Multiple machine learning and artificial intelligence methods were used to analyze the data. These included logistic regression, support vector machine, XGBoost, random forest, and multi-layer perceptron. Patient data was divided into 70% for training and 30% for testing purposes. Tenfold cross-validation was used on the training data set to identify the best parameters for each method. And t-test and chi-squared compared the variables between groups. And so since these methods may be nonlinear, shapely additive explanations removed each item individually from the model to determine which items were the most important for the model and its interpretation. And then sensitivity, specificity, and area under the curve were also determined. And so at the risk of beating myself to the punchline, I do want to take a moment to discuss one of these models in particular, because I recognize that we all have different levels of familiarity with machine learning. And so random forest is a strategy that allows us to create hypothetical decision trees for every conceivable iteration of parameters. And so this covers all possible orders, numbers, and cutoff values within our query, and then gives us a single output. And so here we have a cohort summary. I know it's a little bit small, but it's in your booklet, and this is what we use to train and test the models. And so as previously mentioned, demographics such as age, gender, and race, medications by type, laboratory test values, and ICD diagnoses were obtained via the EMR. And these are the high points of the over 1,800 data points that were obtained for each patient. And so first we looked at the predictionability of these models by examining their sensitivity and specificity. And you can see here that random forest showed the strongest ability on our test data to identify asymptomatic patients who will remain stroke-free. And again, here we demonstrate the model's ability to sort out which patients will remain asymptomatic, and via another method, while all models performed better than random chance, indicated by that black dotted line, random forest once again had the highest performance with an area under the curve of 0.709, with an honorable mention to multi-layer perceptron, the neural network, with 0.706. And so this is a B-swarm plot, which is sort of an information-dense summary of how the top features in a data set impact the model's output. And so this demonstrates that cardiovascular agents at the top were found to lower risk for stroke, while elevated LDL was found to increase the risk. And so other important features included vitamin B deficiency, elevated glucose, and ketones. And so finally, a few practical demonstrations of what artificial intelligence models might look like on an individual basis if we asked to predict the likelihood of an asymptomatic patient who might have a stroke coming into our clinic. And so this first example is this patient has the lowest risk of stroke. As you can see, the summation of these features falls below the threshold to transform into asymptomatic. This patient here kind of has a mix of variables and would be at a medium risk, while this patient falls above the threshold and would be at the highest risk. So our results, random forest machine learning did have the highest specificity at 0.906 for predicting patients will remain asymptomatic, with an area under the curve of 0.709. Top risk factors for symptomatic disease included elevated glucose, elevated ketones, kidney disease, vitamin B deficiency, hyperlipidemia, and the use of psychotherapeutic and neurologic agents. Protective factors included the use of cardiovascular agents and beta blockers. And in conclusion, artificial intelligence methods may improve our ability to determine which patients presenting to a vascular surgeon are more likely to become symptomatic. Many of the same risk factors that lead to carotid plaque formation in the first place also put that plaque at increased risk for causing symptomatic disease. And so future work will include collaborative efforts across multiple institutions in order to study a more diverse population group. Thank you, and I'm happy to answer any questions.
Dr. Pepinos.
Yes, I will ask a question. Some of the parameters make a lot of sense, others remain to be explored. This is extremely interesting data. Are you expecting in the future that a patient will be coming to the clinic and when you click on their name, a a risk assessment for this asymptomatic disease turning into symptomatic will pop up and say, Mr. Pepinos has a 90% chance of becoming symptomatic in the next 5 years. Is that how this will work? And maybe you can explain also a little bit the specificity of 0.9. Does that mean your model can predict 90% of the time who will become symptomatic? And I can only imagine how much better it will become if you added carotid-specific and brain-specific information and imaging and stuff. Very nice work.
Thank you. Yeah, great questions. And so, yes, I think, there's a reasonable expectation that we'll be seeing more of things like this in our future, and possibility of, things like this being built into Epic and Cerner as a tool that we can kind of use to help guide our practice. And then as far, you're totally correct, it would be fantastic to implement, imaging to add to our, repertoire to help kind of solidify an answer there. But yeah, I appreciate your questions. Thank you.
Thank you, and good effort. I have a comment and a question. The comment, the sample size is very small, even to say we are predicting from that sample size, and the fact it is training 70 and 30 tells you don't have a large sample. The question, random forest will not give you a prediction though. Random forest will give you distribution. Logistic regression should be the method to see are you going to predict or not. And this way, the way you present it, which is great, we need a very large study to be able to really predict. The way you presented perhaps factors associated with developing strokes rather than prediction of a stroke, really. That's mine.
Yeah, thank you. You're absolutely correct. It is.
I just wanted to say one thing about logistic regression. Most of these things are nonlinear. Logistic regression is going to have to be a linear factor, so it's not going to be able to take care of nonlinearities.
I agree with that, but this is the closest to predict. Random forest is distribution, stroke versus non-stroke, really.
Thank you. Thank you.
All right, next we'll have a presentation, The Impact of Socio-Demographic Variables on Functional Recovery Following Lower Extremity Amputation, from a group from Loyola.
Thank you for the opportunity to present. I have nothing to disclose. Despite advancing options in revascularization strategies, lower extremity amputation remains an essential component of vascular surgery practice, with 185,000 major amputations occurring annually and over 2 million individuals currently living with limb loss in the United States. SVS guidelines on the management of CLTI emphasizes the critical nature of engaging patients in physical rehab and obtaining prosthetic limbs to optimize their functional status after a major amputation. Post-amputation patients who ambulate with a prosthetic limb have a 15% higher one-year survival advantage versus their non-ambulatory counterparts. Our study aimed to identify variables which were associated with reduced access to prosthetic limbs and not achieving an ambulatory status following major amputation. Our study utilized the lower extremity amputation module from the VQI database and included those amputations that were above, through, or below knee. After excluding those patients who did not have long-term follow-up data or who had undergone bilateral lower extremity amputations, we created 2 separate analyses for each of our primary outcomes, ambulation status and prosthetic acquisition. Each analysis had just under 7,000 patients and a mean follow-up period of around 430 days. These groups then underwent univariable analysis, followed by a binary logistic regression. First, we'll go over the results of the multivariable analysis. This is for the outcome of prosthetic acquisition. This table shows demographic variables, all of which were significant for this analysis. Those patients living in an ADI, or area of deprivation index, in the top 20%, meaning the most deprived areas, female patients, patients of Black, Native American, or Hawaiian Pacific Islander race were all significantly less likely to receive a prosthetic. Commercial insurance and non-US insurance were protective variables, and the mean age of patients confirmed to not have received a prosthetic was significantly older than those who did. When looking at comorbidities, patients who had pre-existing COPD, who were on hemodialysis at the time of admission, who had a non-ambulatory status preoperatively, and who were not on an antiplatelet preoperatively, were significantly more likely to not receive a prosthetic. Additionally, those patients who had an above-knee amputation, those who underwent an emergent procedure, those who were non-ambulatory at discharge, those who were not living at home on long-term follow-up, and those who were non-ambulatory at long-term follow-up were all significantly more likely to have not received a prosthetic. The next table is the multivariable analysis results. This is for the outcome of ambulatory status. Those patients with Medicare insurance, female patients, patients with a BMI less than 20, patients with pre-existing CHF or COPD were all significantly more likely to be non-ambulatory at long-term follow-up. Additionally, those patients on hemodialysis, those non-ambulatory on admission, those who underwent an above-knee amputation, those non-ambulatory at discharge, those not living at home on long-term follow-up, those who experienced post-op joint contractures were more likely to be non-ambulatory. Since female sex had demonstrated statistical significance for the outcome of not receiving a prosthetic, we performed an additional sub-analysis to investigate the differences in the frequency of adverse covariables between the male and female patients. This analysis showed that those of the female sex were significantly more likely to be older, to be non-ambulatory on admission, to have undergone an above-knee amputation, to be non-ambulatory at discharge, and to not be living at home on long-term follow-up, and to be of the Black race. In a similar manner, since the area of deprivation index had demonstrated statistical significance for the outcome of not receiving a prosthetic, we performed an additional sub-analysis to investigate the differences in frequency of adverse covariables. This is between the top 20% ADI, or the most deprived areas, and the bottom 80% ADI, or the lesser deprived areas. This sub-analysis showed that those living within the top 20% ADI were significantly more likely to be younger and to be of the Black race. Additionally, those patients in the top 20% ADI were significantly more likely to be on an antiplatelet at admission and to have undergone an above-knee amputation. Patients in the bottom 80% ADI, or those from the lesser deprived areas, were more likely to have undergone an emergent procedure and to not be living at home on long-term follow-up. Finally, we performed a sub-analysis amongst the 5 primary race categories to determine if there were differences in the rate of prosthetic use amongst the race categories and those who fell within the top 20% ADI. So this sub-analysis showed that Native American, Black, and Hawaiian Pacific Islander patients all utilized prosthetics at a significantly lower rate than their white and Asian patients, who are all living within the most economically stressed neighborhood. While there's overlap between race and ADI, both of these variables had a significant independent association with lack of prosthetic limb use. Limitations of this study include that there was limited information in the VQI dataset on some patient information. There were also a large number of patients that were excluded from analysis due to a lack of long-term follow-up data. In conclusion, living within the most financially disadvantaged areas and race both has a significant independent association with lack of prosthetic limb acquisition following major amputation. Black, Native American, and Hawaiian and Pacific Islander demographic patients experience lack of prosthetic limb use at a higher rate than white and Asian patients. This is independent of medical comorbidities and other socioeconomic covariables. Female patients acquire prosthetic limbs and ambulate less frequently than males after major amputation, largely due to a higher rate of above-knee amputation. And finally, comorbidities, not socioeconomic variables, were the leading drivers of non-ambulation following major amputation. Thank you. I'm happy to take any questions.
Dr. Mattos.
Thank you. Very nice presentation, and it's a subject that we're very interested in, Michigan Vascular, because we live in Flint, and it's a very disadvantaged area. The question I had was any of your data subjective to less frequent follow-up for those who had worse outcomes? Because one of the things that we're looking at, and we have, is an inpatient mobility center with a prosthetist who actually sees the patients in a more frequent manner. And we've been looking at our data recently, and it looks like we have a higher prosthetic use rate and an ambulatory use rate when we have an in-house prosthetist compared to the national data. I was wondering, did you find anything like that in the VQI, and what's your thoughts in that regard? And at Loyola specifically, do you have an in-house prosthetic center that you can actually get these people back sooner to help them physically and emotionally, because that's a big component of people walking again? Again, nice paper. Thank you.
Thank you for the questions. I think that having access to a prosthetist is one of the factors that leads to these certain demographic groups not receiving a prosthetic and not ambulating. Since the Black, the Native American, and the Hawaiian Pacific Islander groups were shown to ambulate less frequently and receive a prosthetic less frequently, it's imagined that that's due both to systemic inequities over decades that have led to decreased financial mobility for these groups, but also the combination of not having access to a prosthetist and having the ability to go to regular appointments for the prosthetic device to be fit. Additionally, I think cost is probably a big component of it as well. We looked at insurance status. Commercial insurance was protective for receiving a prosthetic. But there's a lot of limitations in terms of what insurance will cover and how frequently they'll cover prosthetic devices and replacements. So that was definitely an area for further research.
Ross Milner, Chicago. Really nicely presented, and I think it reinforces for a lot of us that work in under-resourced communities what we see. This is a great opportunity for advocacy in my mind, right? You have reinforced the issues. Insurance, neighborhoods where you have deserts that you can't get prosthesis, that you can't get to a prosthetist, that you can't ambulate. We need to do better. We present this a lot. We need to go to the prosthetic makers. We need to go to our government agencies. We just need, this is where as a society and as vascular surgeons, our advocacy, and I'm guilty of this as well. I'm not trying to say I'm doing it right, because we're not. But we show this type of data a lot, and we all agree it's a problem, and then we leave a meeting like this and don't do much about it. So it'd be nice somehow if we could all come together for something like this and help some of our patients that struggle with this afterwards, and it impacts their lifespan and their ability to do things, because we don't typically do that.
Yeah, I definitely agree. That's a great point. The prosthetic devices and things cost up to $90,000 in some cases, depending on the type of device, but most devices cost at least $2,000 to $3,000, so that's definitely a financial burden for a lot of patients. And
thank you.
Thank you.
All right, this is the last presentation of this session, and I just wanted to point out that all of the 7 presentations that you're hearing this morning are candidates for the Zalagi Award for the best clinical paper of the meeting. The next presentation is radiation exposure from preemptive embolization of the inferior mesenteric artery and lumbar arteries versus secondary interventions for type 2 endoleak induced aneurysm sac growth following endovascular aortic aneurysm repair. This is being presented by Dr. Tran from Mercy One Medical Center.
Good afternoon. My name is Mayanne Tran. I'm a general surgery resident from Mercy One in Des Moines, Iowa. I have no personal disclosures. The long-term results of EVAR have been limited by endoleaks, continued sac growth, and the need for secondary interventions. Type 2 endoleaks are the most frequent indication for secondary interventions, and this is due to back bleeding from aneurysm sac branches, such as your IMA and lumbar arteries. We have previously shown that preemptive embolization of aneurysm sac branches reduces sac growth and decreases the need for secondary interventions. However, it is unknown if such a strategy is associated with increased radiation exposure. Patients who develop type 2 endoleaks have increased radiation exposure from secondary interventions and repeated surveillance CTA. Our hypothesis was that preemptive embolization was associated with a decreased overall procedural radiation due to fewer secondary interventions and less technical difficulty in accessing the source of the endoleak. This was an IRB-approved retrospective cohort study evaluating patients who were treated by EVAR from 2012 to 2022 and followed up until February of this year. We collected procedural data to include fluoroscopy time, dose area product, and total radiation dose. Complete radiation data was available in 112 patients forming this cohort. The patients were divided into 4 groups for analysis. Group 0 patients were those who received no preemptive embolization and no secondary interventions. Group 1 received preemptive embolization only. Group 2 received secondary interventions only. And Group 3 were those who were preemptively embolized and despite this still needed secondary interventions. Radiation data was computed for all procedures, and the patients who were selected for preemptive embolization were studied and analyzed in their assigned group, irrespective of procedural success. The study did not include radiation exposure from surveillance CTAs. Our cohort included 112 patients, and procedural radiation data was computed for preemptive embolization, EVAR itself, and any secondary interventions. The radiation from EVAR alone was not different among the 4 groups. Out of these 112 patients, preemptive embolization was associated with a significant decrease in needing secondary interventions, 14% compared to 35%. This was consistent with our previous studies, which showed similar results. On average, these patients were in their 70s, and most of the cohort were male. Within these groups, we identified the number of patients with endoleaks, as well as the number of instances, the majority being type 2. Radiation exposure was measured using fluoroscopy time, dose area product, and total radiation dose. Patients who did not receive any preemptive embolization or secondary intervention, so group G0, had an average fluoro time of 34 minutes. Those who had preemptive embolization only, average fluoro time was 60 minutes. Interestingly, those who had secondary interventions only, G2, had an average fluoroscopy exposure of 117 minutes, compared to those who had both preemptive embolization and still needed secondary interventions. There was statistical significance between the groups with a p-value of less than 0.001. We saw similar patterns for DAP and radiation dose. For all these variables, this G2 group, who had secondary interventions only, had significantly higher radiation exposure. Here you can again see that this G2 group had the most radiation exposure. You would expect patients who were preemptively embolized and still needed secondary interventions to have the most radiation. However, this wasn't the case. Those who had secondary interventions only had the highest exposure, and this was due to the more increased secondary interventions and the necessary repeated exposure. We found that these G2 patients had on average 2.2 secondary interventions per patient, in comparison to 1.25 for G3. This was significantly higher, with a p-value of less than 0.001. This is further supported by the fact that preemptive embolization and secondary interventions are very different procedures. Out of the 112 patients, 55 were coiled preoperatively, each requiring only 1 session. We embolized a total of 97 vessels, an average of 1.76 vessels per patient, with the majority being the IMA and lumbar arteries. Our technical success rate was 89%. Out of this group, 15% still needed secondary interventions for sac growth. And out of these 55 patients, 5 had a persistent leak at their last follow-up. In comparison, a total of 28 patients required secondary interventions, with almost twice the number of sessions per patient. There were multiple patients, 39%, that needed more than one secondary intervention. To further highlight this difference in technical difficulty, these angiograms demonstrate the number of coils needed for each. Here, preemptive embolization was performed with 2 coils in the IMA, 2 in the right L4, and 1 in the left L4. In contrast, the patient on the right had a type 2 endoleak with an enlarging sac, requiring a total of 21 coils to include the bilateral iliolumbar arteries. In conclusion, the procedural radiation exposure from preemptive embolization was significantly less compared to secondary interventions needed to be performed for sac growth. This is because secondary interventions, after already being preemptively embolized, requires fewer sessions compared to secondary interventions alone. Embolizing the ostium of the vessel before EVAR is technically easier compared to accessing collateral pathways following EVAR. Given this data, preemptive embolization should be considered in all patients with patent IMA and lower lumbar arteries in order to reduce sac growth and decrease radiation exposure. Thank you.
Dr. Milner.
This is a great paper. The next paper needs to be how the impact is on us, because those of us who are losing our hair from having too much radiation exposure, you got to look at that from an interventional standpoint as well. This is great for patients, and it's nice. We should see how the impact is on us as well.
Definitely.
This is really just a comment. I am totally impressed with all the presentations this morning. They have been top-notch, and the only advice I give to all the trainees and whoever's presenting is get these papers. Every one of these deserves a publication in JVS, and it would be a shame if they don't get in there. I just want to applaud you guys all. They were all fantastic. I didn't even know how to ask a question for some of them, so congratulations.
Thank you so much.
Well, thank goodness someone else has a question, so, okay.
Hi, thank you very much. I do have a question. So in terms of your 2 questions, one is what were the indications for secondary interventions? Were they standardized across so we know who's going into the second intervention group? And 2 is, what was sort of the standard modality for secondary interventions? Is it transarterial, is it translumbar, or was there a variety of these? Because I think there's different radiation exposures that are going to come with different modalities, like using translumbar needle track is very little radiation as opposed to trying to go through the iliolumbars, in my experience at least. Thank you.
Definitely. To answer your first question, how do we select patients for preemptive embolization? We have 6 different vascular surgeons in our practice, and over the course of 10 years from 2012 to 2022, data has evolved and our practice has also changed. Studies have shown that, patent IMA carries a 3-fold increase in endoleaks, and patent IMA plus lumbar arteries carries a 6-fold increase. Ultimately, it's up to the operating vascular surgeon to decide. However, we've noticed that, when the IMA is patent, when your lumbar arteries are patent, your IMA, if those are coiled, the lumbar arteries become the next problematic vessel. And we've noticed that with any patency, despite the size, even if they're smaller than 2 millimeters, even if they're stenotic, we have noticed that they also become problematic following EVAR. So, for most of our vascular surgeons, it's up to their discretion, but any patent IMA and lower lumbar arteries are embolized within our group. To address the second question that you asked, for the 28 patients that had secondary interventions, for a total of 54 different sessions, the majority, 90% of them, were performed transarterially by our vascular surgeons. Only 5 were performed by interventional radiology, translumbar for 9.25%. So a majority of them are being done under fluoroscopy by our vascular surgeons.
Thank you very much.
Thank you.
Thanks again to the presenters. I'd like to thank my co-moderators. We have a little break here. I'd like to encourage everyone to get to the exhibit hall. We will start back promptly at 2:15, so please be here at 2:15.